This evening I'd like to dedicate an hour to talking about ventricular overdrive pacing, exactly how that diagnoses each possible SVT mechanism. We'll see that for about 90% of SVTs that come into the lab, ventricular overdrive pacing is the only pacing maneuver that we will need to clarify the diagnosis. So it's a remarkable situation. Someone comes in with SVT, it's potentially very complex. We simply pace from the right ventricle and we learn everything we need to know about the SVT mechanism, and we can move on to ablation. So it's very important that we understand exactly how that pacing maneuver interacts with the rhythm and how it reveals the mechanism of the SVT to us. So a few simple disclosures, nothing relevant here. This is a broad informational presentation. What other people do in their EP lab and how they may use this information in their practice is up to them. We're not responsible. This is a favorite quote of mine. Excellence is doing ordinary things extraordinarily well. Ventricular overdrive pacing is one of those ordinary things that will give you extraordinary results if you do it well and understand what you've done. So we'll focus on something very simple that can give us very profound results in clinical practice and really make a difference for our patients. And for those of us who grew up in the Rocky era, it's a bit of an intellectual triumph to understand this. We have three mechanisms of SVT. The heart supports all of them differently. But if we can have a conceptual framework for how those arrhythmias support themselves, and then understand how pacing into those rhythms from the right ventricular apex can disclose the arrhythmia mechanism to us, it's a powerful place to be. A very strong conceptual framework which will allow you to be successful in the EP lab. As I said, one maneuver will solve 90% of cases, and if you really understand it, you'll understand when it is not enough and when additional maneuvers are necessary. But this will really carry us for 90% of our cases. So you see this ECG. Someone hands you this in the emergency department or in the office, and clearly it's an SVT, about 180 beats a minute like so many of them. More generally, it's a narrow complex tachycardia. So the QRS is narrow, and that's one of the features that readily lets us decide that's an SVT. What's the mechanism? Looking at that ECG, you can't tell. But it can only be one of three things. That is either an AVNRT, it's an AVRT or a Wolff-Parkinson-White type mechanism, or that can be an atrial tachycardia. And officially you don't know, and you have to keep an open mind when you go in the EP lab so that you can really respond to what the mechanism is in any particular patient, because you can be surprised all the time, as we've seen. There is a probability of what that is. For adults aged 40 to 50, AVNRT is the most common, about 65% of the time. An AVRT, or Wolff-Parkinson-White, 30%, and atrial tachycardia, about 5%. So it has to be one of those three. You can't tell which one it is. And here's a slide just illustrating each of those potential mechanisms. For the most common, if it's an AVNRT, that's really an electrical impulse that's spinning right in the electrical junction of the heart, right at the crux. Involves a fast pathway input to the AV node, a slow pathway input to the AV node. Somehow that impulse is rotating right here, and that's AVNRT. It's the most common. If it is a Wolff-Parkinson-White or an AVRT, that means somewhere across the valve plane there's a bypass tract or propagating muscle that shouldn't be there, and that is used to support the tachycardia mechanism. If it's a narrow complex tachycardia, which is all we're going to talk about this evening, then that impulse must be going down the AV node so the ventricle gets activated normally, but then that impulse finds its way back up that bypass tract and spins in a circle, and that's your mechanism of tachycardia. And this bypass tract can be anywhere. It can be in the left ventricle, it can be in the right ventricle, close to the septum, far from the septum. The point is it's a bypass tract, and we have to know when a bypass tract is what is supporting this. And finally, we can have an atrial tachycardia. And that is there's some focus anywhere in the atria, either atria, and it's rapidly firing. Whether it's a triggered event or a micro-reentrant focus, it really doesn't matter. The point is there's some focal source that's giving rise to the tachycardia. And here, as a patient will age from very young to old, the probability of the mechanism changes over that person's lifetime, as you can see. The atrial tachycardias and the AVNRTs become more common because we're predisposed to them as we accumulate atrial pathology over our lifetimes. The Wolff-Parkinson-White, very common in very young children, becomes less and less as you get older. Why is that? Because the bypass tract is essentially a congenital defect, and over time they tend to go away by themselves. That said, you can have a very strong bypass tract which doesn't manifest itself until you're age 40 or 50 because it's relying on the other pathological or structural changes in your atria that finally allow it to actually support a tachycardia. The person comes in with the arrhythmia. And we've seen that in our lab, so we can't be fooled, have to stay open-minded. Nevertheless, everyone has sort of that pre-test probability of what the mechanism most likely is in any one patient. So as you know, in the EP lab, for an SVT, it is traditionally a 4-catheter study. And here we see what that looks like in RAO and LAO views. So we have a diagnostic catheter in the high right atrium. We have one in the His position. It's straddling the tricuspid valve annulus so it can record that conduction system signal. We put a catheter through the coronary sinus, comes out here to the lateral wall of the left atrium, left ventricle, lets us know what's going on the left side of the heart. And finally, there is a catheter that is positioned in the RV apex. And this is the one that we're going to use to perform ventricular overdrive pacing. So this is a quick study on how intracardiacs work. This is a sinus beat. So here we see a P wave followed by a QRS. Clearly that's sinus. But when you have the intracardiac information, you can see that that sinus beat begins in the high right atrium, propagates towards the low right atrium, activates atrial tissue at the His position, and then spreads laterally across the left atrium. So that's atrial activation during sinus rhythm. That impulse conducts slowly over the AV node, engages the His-Purkinje system, and you record this His potential, and then conducts to the ventricle. The first breakout point in the ventricle is usually the RV apex because the conduction system exits actually near the apex of the heart. But then you see that ventricular complex record almost as early at the level of the His catheter while you see the ventricular impulse spread across the left ventricle, and it's seen by the His potential. The very earliest ventricular signal is not from the intracardiac catheter, it's from the QRS complex. So as soon as your QRS begins to deflect, that's the earliest ventricular activation anywhere. From the intracardiacs, you get a sense of where that likely is, but the earliest event occurs here. And it's the same for a P wave. So we're going to rely on the surface ECG in our diagnostic study to provide us actually the most precise information when ventricular activation really starts. And we'll take that in precedence over the intracardiac signals. And I'll show you where that becomes important. So we have our patient in the lab. We know they have a history of SVT. We have our catheters in position. Our next task is to induce the arrhythmia. So we try to induce SVT. How do we do that? We play electrical tricks on the heart, in short. You can do atrial decremental pacing, maybe from a cycle length of 600, down by 10s all the way to the block cycle length. Around the block cycle length, we can just do burst pacing at a constant cycle length, maybe 10 to 40 beats. That can be enough to stir up the SVT. We can do atrial extrastimulus testing. So we pace at a constant cycle length, and then after 8 beats, we put in an early beat. And that will increasingly impinge on the refractoriness of the AV node. We might see conduction across the AV node switch from the fast pathway to the slow pathway, and we get that AH jump, which shows us the presence of dual AV nodal physiology, which is important for the substrate of AVNRT. But even if it's present, you may not have an AVNRT, but it is a first clue. We get that from atrial extrastimulus testing, which can put us into the arrhythmia. Some SVTs only want to start with ventricular extra stimulus pacing, and so we can perform that from the ventricle as well. If we're failing at this point, we will add isopril, usually 0.5 to 4. The trick here is to perturb the nervous system. So we can induce during loading, during steady state, during washout of isopril. We keep introducing changes to the patient, which may get the arrhythmia started. And finally, some individuals have very particular clinical circumstances that they need to start their arrhythmia. It can be stress, it can be emotion, it can be music, fumes, caffeine, perfume. We've had patients sniffing perfume in the EP lab. We've had them inhaling diesel fumes in the parking lot before they come in. All these things to trigger their SVT because we want to see it in the lab. So these are our tricks for getting the SVT started. And here we see on intracardiacs what starting SVT can look like. Here's our sinus beat. These are 3 leads of the surface ECG. And here's our intracardiacs. We have a His catheter and coronary sinus catheter and our RV apical catheter. And you can see here from sinus rhythm, we burst pace for 15 beats from the proximal poles of the coronary sinus at a cycle length of 350. That's probably very close to this patient's AV Winky box cycle length. And lo and behold, when we come off pacing, the patient's in SVT. So all of a sudden, SVT, tachycardia, cycle length 342, and now we have to figure out how this tachycardia is supporting itself. There's a little bit of a panic. I think everyone feels at this stage. It's like, we got it, now what are we gonna do? And what we do is we keep calm and we perform ventricular overdrive pacing. Very calmly, very mechanically, we set up and we do this. So it's very simple. You start the arrhythmia and we'll go through this very deliberate process which will give us our diagnostic information. So, to perform overdrive pacing, first of all, we measure the tachycardia cycle length of the SVT. In that example, it was 342. And then from the RV apical catheter, we're going to burst pace 10 to 30 milliseconds faster than the cycle length. We'll pace, not for very long, pace until the pace QRS stabilizes for 5 to 10 beats, and then stop. Usually that's about 30 beats total. We go for these extra beats to beyond QRS stability to allow for the pacing to advance atrial activation, and we'll see that. If when we stop pacing, the patient continues to be in SVT, we're just going to come on pacing and do it 1 or 2 more times. If they're still in SVT, we'll lower the pacing rate by 10 milliseconds, and we'll do it again 1 or 2 more times. And if they're still in SVT, we'll lower it, do it again 1 or 2 more times, and eventually we'll break the SVT. Now the patient is back in sinus rhythm. Everyone be calm. We can go back and look at our pacing trains, make key observations that will diagnose the tachycardia for us. So 3 or 4 successful pulse trains is perfect, and we can reinduce the SVT to complete this if we feel that we need to. So this is what this looks like in the EP lab. We've induced SVT. So here we are in SVT, tachycardia cycle length of 260. So we start pacing at 250, and we pace for 20 beats. And we look, and on the surface ECG, you'll see that the surface QRS starts to change, and then it stabilizes. So this time, when the surface QRS is changing, we call that the transition zone, and everything beyond that is stable. Once it's been stable for 5 to 10 beats, we stop, and we observe that SVT continues. So great. We lower the pacing cycle length by 20 milliseconds, burst pace again into the SVT, always from the RV apex. This is ventricular overdrive pacing. We observe the transition zone. We observe steady state. We've been in steady state for 5 to 10 beats. We stop. We see that SVT continues. So we do it again, this time 30 milliseconds faster. Observe a transition zone, steady state. We stop. SVT continues. So do it again, 40 milliseconds faster, pace, steady state, stop, and now we're back in sinus rhythm. So we have all these pulse trains, and in some of them that will have been performed well, we will see the tachycardia mechanism. So now back in sinus rhythm, we can go and look at those pulse trains and see what we have. So let's give one slide to the concept of the transition zone. This is when you start pacing and the QRS changes until it gets to steady state. Why is it changing? Well, you're pacing from the ventricle. Why does it reach steady state? Let's understand that. So here we are in an SVT using a bypass tract. So this is the SVT spinning. Now when we start pacing from the right ventricle, remember we're pacing faster than the tachycardia. So we'll capture a little bit of the ventricular muscle. The next time we pace, we're going to capture even more of the ventricular muscle. So each time we pace, when we're capturing more and more ventricle, more and more of that QRS is going to be coming from our pacing catheter rather than from the SVT, right? So we're going to see the QRS change as it represents a hybrid from the SVT and our pacing to where either the entire QRS is arising from our pacing catheter, or we've met a steady state where a fixed fraction of it is coming from the pacing and the rest of it is coming from the SVT. So we can see if we had a right lateral pathway and we pace into that SVT, after we've captured about 2/3 of the ventricle, our pacing impulse will be participating in the tachycardia. It'll go up the bypass tract, come back around, go up, come back around. This much of the ventricle will be from pacing, this much of it will be from SVT. If that mechanism happened to be a left lateral bypass tract, before we participate in the tachycardia, our pacing stimulus will have occupied the entire ventricle. So much more of that QRS will be coming from our pacing catheter than from the SVT. And the same is true for an AVNRT or an atrial tachycardia. Our pacing catheter has to occupy the entire ventricle before that impulse ever enters into the AV node or into the atria to interact with that tachycardia mechanism. In this case, the paced QRS represents what a paced QRS would look like if we weren't in tachycardia. Here, it looks like a hybrid or a fusion between a fully paced QRS and the narrow complex that we saw during the tachycardia. So that's the transition zone. And we'll get a little bit of information from the transition zone that will help us with our diagnosis. So let's look at the concept of ventricular pacing for each of the 3 possible SVT mechanisms, starting with the most common, which is AVNRT. So we're not supposed to know up front, but let's say we happen to know that the patient's SVT will turn out to be an AVNRT. We have this rhythm spinning in the center of the heart. We think of it as using a fast pathway, slow pathway, inputs to the AV node, and somehow it's spinning here involving both atrial and AV nodal tissue. It's a typical AVNRT in 94% of cases, and what that means is that the retrograde conduction is going up this fast pathway. So the circuit is slowly down the slow pathway, and in the time that it's propagating down to the ventricle, it's also propagating back up to the atria, such that the atria and the ventricle are activating almost simultaneously. And it's the only tachycardia that will do that. So if we can measure a VA interval during SVT that is less than 70 milliseconds, only AVNRT can do that. And if that's the case, we've already got our diagnosis even without pacing. We'll pace, but that already is going to be a very strong clue, that simultaneous activation, that this has to be coming from an AVNRT. If it happens to be longer than 70 milliseconds, it can still be an atypical AVNRT, which can be the case in 6% of cases. Atypical AVNRT is not exactly the reverse of a typical AVNRT. Nevertheless, it will respond to our ventricular overdrive pacing maneuvers the same way as a typical AVNRT. So the pacing maneuvers are going to disclose to us that it is an atypical AVNRT and not a WPW. So we'll still hold out for the pacing maneuvers. If we've got that interval less than 70 milliseconds, we've already got our diagnosis. If we don't, the pacing maneuver is still going to reveal it to us. And we can see a typical AVNRT often on the surface ECG, really. You know, when you compare it to the sinus ECG, you can sometimes discern in V1 little terminal P waves at the end of the QRS complex that can be visible in V1 and also in the inferior leads. And on the surface ECG, you can go from earliest V on the QRS to earliest A on that little P wave. And if that's less than 70 milliseconds, or really less than 2 of the small boxes, you've got a typical AVNRT. You really have diagnosed it from the surface ECG. You don't always get to see that, even in typical AV node reentries, but it's nice to know that sometimes it does disclose itself. Here is a classic case of AVNRT. It is a female, most common in females. She's in her 5th, 6th, or 7th decade. She's finally come to the emergency department with a narrow complex tachycardia that terminated with adenosine. But you talk to her, and for several years now, she's been having these things at home, and they've stopped with breath holds or bearing down. Now she can't control it, and she's in the emergency room. That's your classic story for AVNRT. You've almost made the diagnosis just by hearing that. But again, we keep an open mind because it still could be anything. So, once again, we take her to the EP, we take this patient to the EP lab, they're in sinus rhythm, we burst pace, that's enough to put them into into SVT, and we proceed with our EP study. In sinus rhythm, we've made a couple of observations on our His catheter. We have an AHV, so we know what the A and what the V looks like at the His position. So in SVT, on that catheter, we're going to recognize those things. We see the His potential, we see the big ventricular complex, the small atrial complex, and at the His position, we measure what's called the septal VA interval. It's best to measure it at the His position because that is most septal. So we take the earliest intracardiac A to our earliest V on the surface ECG, and we measure that interval. Here it's 16 milliseconds. That's less than 70. We know from that measurement it's an AVNRT. If we didn't have a good catheter here, we can use the proximal CS as a surrogate. And you see that measuring from earliest A to earliest V on the surface QRS, it is 30 milliseconds. Still diagnostic of an AVNRT. So if you don't have it, try to use the His. If you can't, the proximal CS often works. And we have our first interval, which is the septal VA interval. So we write that number down in our notebook because we're going to need it. We observe that during SVT, the QRS is the same as it was during sinus rhythm, and that the atrial activation sequence on the CS catheter is the same. It's not particularly changed from this, which tells us that that tachycardia is activating over the AV node the same way that it did in sinus rhythm. So those are things that we can observe just from the tachycardia when we go back after all our pacing studies to analyze this thing. So we make those initial observations. Then we're going back and we're analyzing our overdrive pacing routines to see what they can reveal to us. So here we go, RV apex, 13 pace beats. Tachycardia continues after ventricular pacing. We look at the transition zone, the time that the QRS changes, so we identify this. And so we feel good about ourselves that we have a legitimate pacing maneuver. And again, what does the transition zone represent? When AVNRT is spinning in the middle and we begin to pace here, we will progressively approach that tachycardia and then begin to pace through that tachycardia. The tachycardia is going up the fast pathway, down the slow pathway, and as we overdrive pace, eventually our paced impulses will also go up the fast pathway, down the slow pathway, as our pacing overtakes and participates in the tachycardia. The time that it takes to catch up and begin participating is the transition zone. That's important because if this is an AVNRT, we will not advance the atria during the transition zone. Why? Our impulse hasn't even gotten to the tachycardia while the QRS is still evolving. So if we advance atrial activation during the transition zone, it's probably not an AVNRT. If we advance it several beats, usually 4 beats after the transition zone, that's behaving consistent with an AVNRT. And that's something that we look at. How do we measure atrial advancement? Like this, we see our transition zone, we know we've been pacing at a cycle length of 310 milliseconds, so I make a caliper electronically of 310 milliseconds, put it on one atrial signal, and I see, does this reach the next atrial signal? And the answer is not yet. But here, if I advance my caliper, sure enough, I've pulled in that atrial signal, it's now at my pacing rate, and I know I have advanced the tachycardia. Now I have truly overdriven it. So we have successfully done VOP, ventricular overdrive pacing. As soon as I advance the A, I know I've been successful. And when the atria is consistently advanced, we make our second measurement, which is the paced VA interval. For the advanced atrium, we go from the onset of the pacing spike on the QRS, and we measure to that earliest advanced A. So here we will get a paced AV interval of 165 milliseconds, and now we can make the first measurement, which is actually down here. The paced VA interval minus the septal VA interval, 165 minus 16 equals 149. It's greater than 85. When it's greater than 85, that's consistent with the AVNRT. When it's less than 85, that's consistent with the WPW. So those numbers have been validated in advance. We have them in our head, but we've just done a study, made measurements that are consistent with published results for AVNRT. Lastly, when we come off of our pulsing train during ventricular overdrive pacing, we look at the response. So here's our last pace. This is the last QRS we paced. This is the last atrial signal that we've advanced. So after that, whatever happens is arising from the SVT and not from our pacing. So what's the very next thing that happens? The next thing that happens is we record a His signal and then a ventricular signal. So we call this a VAV response, or more precisely a VAHV response. VAV or VAHV happens in AVNRT or WPW. So this is not behaving like an atrial tachycardia. And here we measure our post-pacing interval, which is the interval from our last stimulus to our first return on the same pacing catheter, the RV apical catheter, and we see that that is 526 for a tachycardia cycle length, which is 320. We take the post-pacing interval minus TCL, 526 minus 320 equals 206, and that's above another predefined cutoff of 115. Greater than 115 is AVNRT, less than 115 is WPW. So we have 2 measurements now and 2 independent observations which are supporting our diagnosis of AVNRT. So again, the septal VA interval is going to be very short because activation of the ventricle happens at the same time as activation of the atria. The paced VA interval, when we overdrive, the time from our pacing to where we activate the atria is going to be relatively long compared to the septal VA interval. So that when we take the difference, long minus short, we're going to get something long, truly above 85, which is our cutoff. Also, our post-pacing interval is going to be long, because what does that represent? The time for our pacing stimulus to travel to the tachycardia circuit, loop through the tachycardia circuit, and come all the way back to our pacing catheter to record it. That's going to be long. So if we go something long minus the tachycardia cycle length, we will get something long again. So above 115 milliseconds, our predefined cutoff. All of our measurements now supporting an AVNRT. That's a summary again of what we just said. I won't belabor it this evening. We've made our diagnosis, we're confident in our diagnosis, and we can go on to using cardo, finally, and we can do our ablation. So in our minds, we're conceptualizing this. This is where the hiss is. This is where the compact AV node is. We don't want to damage either of those structures. This is the coronary sinus, and you can see right in front of the coronary sinus, but behind the tricuspid valve is the slow pathway input to the AV node, and that's the structure that we want to ablate. So we have an ablation catheter that's come up the IVC, is sitting in front of the coronary sinus, not above it, and it's that strip of tissue there that we want to ablate to cure AVNRT. So it looks like this. Here's our ablation catheter at the tricuspid valve annulus. It's at the level of our coronary sinus ostia, which is this. So we're well below the compact AV node and hiss, which is up here, and we can successfully ablate for AVNRT. That's awesome. That's a hard one, and that's the most common one, and we figured it out. So the other ones will make more sense knowing that. Let's talk about AVRT. Again, there's an accessory pathway or bypass tract. In a narrow complex tachycardia, it's going down the AV node and up the bypass tract, wherever that is. And that's our mechanism, and we want our pacing maneuvers to prove this for us. Our ablation target this time will not be the slow pathway to the AV node. We're going to try to ablate this accessory pathway wherever it is. So let's see how the maneuvers play out. Once again, ECGs in patients with AVRT or WPW. You may see a delta wave on the sinus ECG. That's if the pathway conducts forward. And that delta wave represents ventricular activation over the accessory pathway before ventricular activation over the AV node takes over the ventricle. So delta wave, and then upstroke of the QRS when the His-Purkinje system takes over. If you don't see delta waves, your patient can still have WPW, because some of those bypass tracts only conduct backwards and you'll never see the pre-excited signal. So delta waves are a nice clue. Again, they're never going to be diagnostic for us. An orthodromic AVRT is narrow complex, and it will have an RP interval of greater than 70. Less than 70 is AVNRT. Now we're greater than 70. It could be an atypical AVNRT, it could be an AT, and it could also be WPW. We don't know yet. We just know it's not a typical AVNRT. So armed with that information, here is a classic case. It is a male. These occur more commonly in males. It's not a young male now, but he's having his palpitations since childhood. Another big clue that this might be bypass tract mediated. In him, we see no pre-excitation on the ECG. Doesn't change our suspicion at all about the possibility of AVRT. So we're going to do the same pacing maneuvers, and we're going to see the same response. We're just going to make some different measurements which are going to make the distinction. So in AVRT, let's think about what the transition zone represents. Here we have a tachycardia that has this pathway, down the AV node, up a bypass tract. When we start pacing here, we are going to be in that tachycardia circuit almost immediately. And that's important. The paced QRS, once it stabilizes, will have a fused morphology between the tachycardia and between what a fully paced one would look like. And we'll see that we're going to advance atrial activation before the transition zone finishes. And that's because almost immediately our pacing impulse will get into the tachycardia and conduct through the tachycardia circuit. So before the QRS is mature, we will have advanced the atria. And you need a bypass tract to be able to do that. So that is going to be one of our first observations. So here we see sinus rhythm. A PAC puts us into the SVT. We see that it has an eccentric pattern along the CS. So it's starting in the lateral CS and propagating towards the midline. That's your first clue that it's coming over a left lateral bypass tract. That said, we're still going to do our diagnostic maneuvers. We measure our tachycardia cycle length, and then we measure our septal VA interval. Here it's earliest septal atrial activation to earliest septal ventricular activation, and we get a measurement of 192 milliseconds. So we're writing these things down as we go along. Because we will do our pacing maneuver, once again, don't think, just go down by 10 milliseconds and pace from the RV apex into the tachycardia. We see our transition zone. After the transition zone, we observe that we've advanced the A. When we've advanced the A, we measure our paced VA interval. Here it's 266. From the onset of pacing to the earliest atrial signal, 266. We have two numbers now. We can do our calculation. Our paced VA interval minus our septal VA interval, 266 minus 192 is 74. And look, that's less than 85. If it was AVNRT, it would be above 85, but it's less. So we say this is behaving like a pathway from our first measurement. Our post-pacing interval, very much the same. Our last pace QRS, what happens after that? Here's the last atria we advanced. And then we go his ventricle. So we have that VAV response or that VAHV response, which is typical of AVNRT and AVRT. This will still tell us the difference because we measure our post-pacing interval. Last pace complex, first return signal on the pacing catheter, 472, compared to a cycle length of 382. 472 minus 382 is 90, and that is now less than our cutoff of 115. So we have two short calculations, which tells us this is a WPW mechanism. So that lets us sniff out the difference, and we start to see the tachycardia through the pacing maneuvers. The septal VA interval here is short because these are activating simultaneous. In this scenario, they are long because the septal VA interval, well, the V finishes here, or sorry, the V starts here and the A starts here. Well, that's a long interval. That's not behaving like a WPW. Post-pacing interval for AVNRT is long because the stimulus has to go up here, around the circuit, all the way back down. That takes forever, whereas it's going to be short in this case because your pacing is already within the tachycardia circuit, and therefore your calculations are going to be short in the case of AVRT, and they're going to be long in the case of AVNRT. So we make the numbers fit the intervals. It makes sense based on our conceptual understanding of that SVT, and we can get on with the more important task of catheter ablation. So here we see a left lateral accessory pathway way out along the coronary sinus. We've gone transseptal, put an ablation catheter on that bypass tract, and we eliminate the bypass tract. And we can do that because we made a correct diagnosis. And we prove the diagnosis. Atrial tachycardia is a bit of a wild card. It's out by itself. They're usually easy to distinguish, but we still want to be able to prove our atrial tachycardias. So again, this is a point source firing somewhere in the atria. And that's your tachycardia mechanism. Here is where they typically come from, around the pulmonary veins in the left atria and along the crista terminalis in the right atria. Narrow complex tachycardia, we have a P-wave morphology that looks non-sinus, and here we are trying to ablate at the site of earliest activation. So we want to find where that little spot is and zap it. Again, a very different ablation target than its two predecessors, so we want to have made the diagnosis so we know we're curing the patient. These are ECGs that turned out to be atrial tachycardia. Here's one-to-one AV conduction. You see it's a non-sinus superior P wave, that's a clue, but it could be AVNRT or AVRT. Same in this case. If that ATAC is 2-to-1 A to V, there's twice as many A's as V's, That cannot be a WPW because every circuit there has to involve the A and the V, but it can be an AVNRT because an AVNRT does not have to involve the ventricle. So you still don't have your diagnosis for sure when you have a 2-to-1 tachycardia on your surface ECG, and it behooves us to be academic in the EP lab. Here's the smoke and mirrors. We have a female. She's in her 6th decade. She's in the emergency department with a narrow complex tachycardia. They gave her adenosine and it terminated. Sounds like an AVNRT. So again, let's think about a transition zone. We've got a focus here that's firing away, activating the atria like this, like sunbeams. We are going to pace from the RV apex and send impulses up through the AV node into the atria. We are not participating in the tachycardia mechanism. We are activating the atria in an entirely different way than the tachycardia. And we're going to see that change in atrial activation sequence for atrial tachycardias, which we did not see for AVNRTs and AVRTs. Because in those two cases, our paced impulse conducted through the tachycardia mechanism. Here we're not conducting through the mechanism at all. We are simply overdriving an entirely different mechanism. So let's just see how that plays out in the EP lab. Once again, here we're in our SVT. We start to pace from the RV apex. We observe there's a transition zone. After a while, we will begin to advance the atria to our pacing cycle length, so our overdrive maneuver is successful. But you can see here that compared to the SVT, the way the left atrium activates is shaped slightly different. It's subtle, but it is clear and it is consistent. And that's your first clue that you are not pacing through the tachycardia mechanism. This is something else. We can measure paced VA intervals, septal VA intervals. It turns out that none of those are relevant in an atrial tachycardia. So write them down. They don't mean anything. Don't expect them to make sense. And we'll get our diagnosis differently. Such as this: pacing in the right ventricle. We stop pacing. We identify our last advanced atria. So we're pacing down here. Everything we pace sends a signal up to the atria. Then we stop pacing. The next thing that's going to happen comes from the tachycardia. What is the tachycardia? It's an atrial tach. So that atrial focus that we've beaten down with our pacing comes back to life. And our next signal then is an atrial signal. And that atrial signal then conducts down to the V. We call that a VA-AV response. And that is diagnostic of an atrial tachycardia when you can make that observation reliably. Post-pacing interval, make the measurement. Again, it's not a relevant measurement for an atrial tachycardia. We've made the atrial tachycardia diagnosis by seeing this VAAV response, noticing the activation sequence change on the prior maneuver. Now that we know it's an atrial tachycardia, we have the business of using CARTO to map in that atria, find the earliest site of activation in the atria, which in this case was right on the interatrial septum, and burn right at that, ablate right at that site of earliest activation to abolish the tachycardia. So we clarified the diagnosis of atrial tachycardia. We proved it to ourselves, so we can ablate in a way where we're confidently addressing the mechanism. And believe me, it's easy to get confused and lost in the EP lab if you start making mistakes, start taking shortcuts. You've ablated for a while, nothing has happened, and you're beginning to second guess yourself. So it's important that we take the time to make each of the observations as they occur, not get ahead of ourselves, and arrive at a firm diagnosis. So again, atrial tachycardia, it's got a long SVA interval. The activation sequence will be eccentric in 25% of cases. The P wave is non-sinus. There can often be more A's than V's, which is already a clue. Another major clue is that you do ventricular overdrive pacing, and no matter how many times you do it, your paced impulse never gets up to the atria. That happens in 50 to 80% of cases, and that's a major clue that it's an AT. If you can't go backwards through the AV node in an atrial tachycardia, it's probably an atrial tachycardia. Because for a heart to support an AVNRT or an AVRT, the AV node needs to be able to participate in these things. So this is a big clue when you can't influence it. If you do successfully overdrive pace and advance it, atria is advanced after the transition zone, just like an AVNRT, but there'll be a different atrial activation sequence, which is unlike AVNRT, and there's your observation supporting your diagnosis. And then finally, following overdrive pacing, when your SVT continues, you get this VAAV or a VAAHV response, which also can only happen in an atrial tachycardia, and you have made your diagnosis. That's a lot of information, and that's a lot of technical information. But hopefully it kind of makes sense, and we can start to, each of these arrhythmias can start to get a personality which we can exploit to distinguish between them, be effective in the EP lab. So for those of us who still watch James Bond, maybe we're shaken, but hopefully not stirred at this point. So ventricular overdrive pacing, essential for the SVT diagnosis in the EP lab. You see an SVT, don't panic. The first thing you do is very mechanically overdrive pace it from the ventricle. And just keep doing it at different cycle lengths until the SVT breaks, and then go back and analyze what you did. You make the observations slowly and carefully, and you'll probably have your diagnosis. In 90% of cases, that's the only maneuver you need. There's a laundry list of additional maneuvers you can do. You only need them in maybe 10% of cases. So understanding this is really important. It's not difficult when you practice, and it becomes the basis for appreciating what other maneuvers are necessary and appreciating what those additional maneuvers can contribute.